Thank you, everybody, for showing up. Today's topic is pediatric trauma grand rounds. Dr. David Wesson, who's one of my mentors and actually my boss when I did my pediatric surgery training fellowship at Texas Children's Hospital. This is a picture of the outpatient center in Houston. I have this 55-page CV, and I thought I'd summarize it to the salient points that are applicable here. He's a Canadian. He went to medical school at University of Toronto. He did the Galley course for general surgery residency at U of T. He did his fellowship at Sick Kids also.
This is a VGH site. We don't have a hookup for audio-visual.
We can see you. Hear you. Yeah.
Are you able to hear us? Okay, I'll have to phone the room.
Should I continue?
Yeah.
Okay. Research fellowship at Harvard, and just recently a certificate of academic medical department leadership at University of Texas. He was at the Hospital for Sick Children for many years, where he was associate professor, director of the trauma program there, chair of the trauma committee for the Department of Surgery at University of Trauma. And it was there where he was a primary author on the Sentinel paper that suggested non-operative management of splenic trauma. It was also there that he was a founder for Safe Kids Canada and many other trauma programs. He went to Cornell Medical Center and was chief of pediatric surgery there for a few years and attending at the Memorial Sloan Kettering Cancer Center. And since 1997, he's been at Baylor College of Medicine and Texas Children's Hospital in Houston. Currently, he's the associate surgeon-chief at Texas Children's. He's chief of the Department of Surgery also. He's a trauma medical director there. He's a tenured professor of surgery at Baylor College of Medicine. This is where Michael DeBakey and Kenneth Maddox have resided and currently reside. He's a trauma system surveyor for the American College of Surgeons, and I think, again, he's going somewhere to another site in a couple of weeks. He's a founder of Safe Kids Canada. He's a founding member of the International Society of Children and Adolescent Injury Prevention and still has a lot of ongoing say both in Canada and the States for trauma and injury prevention. He's been the president of the Trauma Association of Canada. He's a reviewer for the Pediatrics Journal as well as the Injury Prevention Journal. Needless to say, he's had numerous invited lectures as well as paper presented, over 100 peer-reviewed papers. He was a primary author on the Sentinel paper back in the early 90s of the ruptured spleen, when to operate. Many other papers, dozens of books, chapters, and he was the first annual Murray Girardi lecturer at the Trauma Association of Canada conference in Banff of 2011. So, with further ado, I'd like to introduce Dr. Wesson, my mentor in chief, and his topic.
Well, Naomi, thank you very much for the kind introduction. There we go. It's certainly an honor to be invited to visit with you. The last time I was in Vancouver, or in Victoria, I ended up in the emergency department of this hospital, and I must say that I was very well treated, and I saw the best of the Canadian healthcare system, which was quite gratifying, actually, for me at the time. And also thank you for the kind introduction. I really do appreciate it. I chose to talk about the history of splenic injuries because I think it illustrates a lot of themes that run through surgery in general. Things like how surgery changes and evolves over time and what factors contribute to those changes. How surgical dogma develops and how difficult it is to dispel it. And how relatively small people like I was at the time can make some contributions, assuming you have something to say and some good data. So this question of how best to manage splenic injuries has been controversial for over 100 years. And I hope to show you what was really behind the controversy and explain it and to bring you up to date as to what the current management or the best management of splenic injuries really is. I have no conflicts of interest to disclose, and I'll try not to steer you in the wrong direction. Just to show you a little bit of Texas mentality, I'll promise not to shoot you either. This is the hospital where I work now. I started out my career at the Hospital for Sick Children, as Naomi mentioned. I was there on the faculty for 13 years, and it's where I became interested and got involved in all the controversies about the management of splenic injuries. And but I went to Houston in 1997, and I've been working at this hospital ever since. This is the inpatient tower. It's the largest freestanding hospital in the United States. It has over 200 ICU beds in 6 different units. This is the research center, which is adjacent to the hospital. This is the clinical care center, which is the outpatient facility where we do all our day surgery, or most of our day surgery. This is the recently opened pavilion for women, which was added so that we could care for high-risk pregnancies and deal with babies who are expected to be born with major congenital anomalies like major cardiovascular problems, esophageal atresia, abdominal wall defects, sacrococcygeal teratomas, and diaphragmatic hernias. So all these babies are now actually born in the Children's Hospital. There's a neurological institute, which is part of the hospital, and recently we've opened a west campus, which is about 25 miles to the west of the main campus in one of the growing suburbs in the city. So altogether, it's quite a complex organization. It's quite a thrill for me to be able to work there. I think that when we're talking about splenic injuries, it's important to remember that the primary goal in treating them is to prevent exsanguinating hemorrhage, which is always a risk. And the second goal, although important, is to save the spleen if possible, but it's not the primary purpose. I'm going to talk a little bit about the function of the spleen. I'm not going to say very much about it. There's really not much that needs to be said at this point in history, I think. I'm going to talk a little bit about how the management of splenic injuries evolved over time, and I'll spend most of my time on that part of it. I'm going to summarize what I think is the current state of the art right now, what the best practices are, and what determines what those are. And finally, I'll try to say a little bit about what I consider the themes or the lessons that we can glean from this story about the management of splenic injuries. The 2 major themes that I want to develop are that surgery is really shaped by our understanding of human biology as it evolves over time, and the medical technology and the tools that we have at our disposal to care for patients with different medical and surgical problems, and that local resources and conditions determine what is practical and what is important. There's really no one right way for all times and in all places to manage patients with splenic injuries, and I'm going to tell you a little bit about it, why that is, in my opinion. Depends a lot on the people that are available, their skills, their knowledge, and their experience with dealing with children, and the facilities, including the state-of-the-art radiological services, available operating rooms, ICUs, blood banks, and all those things that we take for granted in our leading hospitals nowadays. The spleen at one time was considered to be the seat of the emotions, and the word spleen was synonymous with a feeling of anger or ill will, but it's obviously not that anymore. Now we understand what it's there for. It's a lymphatic organ, lies in the upper part of the abdomen. You all know a bit about the blood supply and how vascular it is. It has 2 main functions. One is to serve as a filter for the blood to remove old blood cells, red blood cells, and bacterial and other particulate matter from the blood, and also to participate in the immune response. It stores B and T lymphocytes and helps initiate the immune response to foreign antigens. This is the sort of state of the art 100 years ago when the writing about splenic injuries first developed. The anatomy of the spleen was well known, but there was no knowledge about what its function was. In fact, most people thought it had no function. The technology that it was available was really non-existent. The only way to assess and manage patients with a splenic injury was based on clinical examination. There was no imaging. You couldn't keep an IV up. You couldn't transfuse patients who had ruptured spleens. But anesthetic was available, and there were skillful surgeons at the time, and it was possible for any real competent general surgeon to do a splenectomy in cases of ruptured spleen. And it's important to remember that surgeons of the early 20th century were aware of the risks of exsanguinating hemorrhage, and this was kind of the overarching consideration in managing patients at that time. So, in other words, splenectomy was really the only practical way to deal with the splenic injuries to save the life of a patient who was bleeding to death from a ruptured spleen. And Cocker, who was the first surgeon to receive the Nobel Prize, sort of summed it up in a statement that he published in 1911. Splenic injuries, injuries of the spleen demand excision of the gland. No evil effects follow its removal while the danger of hemorrhage is effectively stopped. And that was sort of the prevailing wisdom for at least the next 50 years. Splenic injuries were diagnosed clinically. The spleen could be removed fairly easily by any competent surgeon. There was no other way to help the patient. And there was really no known downstream consequences of taking out a spleen. As far as everybody knew at the time, it had no long-term complications. Then in 1932, McIndoe, a British surgeon, introduced a new concept that also had a major role in the attitudes and the practices of people who are looking after patients with ruptured spleens, the idea of delayed rupture of the spleen. He actually published a very short series of cases. They weren't well documented. And this problem of delayed rupture was rarely seen by other people, but it became ingrained in surgical mentality. And I remember when I was a resident in Toronto General in the 1970s, if you touched the spleen and saw 2 red blood cells coming off the surface of it, you took out the spleen. If you were doing a gastrectomy or a colectomy or something like that, it was really considered to be. And the main reason was that there was this widespread awareness of the risk of, or at least the potential or perceived risk of delayed rupture of the spleen. And the spleen was sort of like a ticking time bomb that could go off at any time over the next few days or weeks. Remember that there was no other way to diagnose splenic injuries except for the clinical diagnosis, and it was a pretty easy operation to do, and there were no long-term consequences, as I said. So this was sort of the context and the prevailing wisdom as the middle of the 20th century approached, and that was about to change. And as far back as 1919, there was some evidence that the spleen had an important role in immune function. But the most important and seminal paper that really changed people's attitudes was a publication in the Annals of Surgery by King and Schumacher of 5 cases of overwhelming sepsis in children who had had a splenectomy for spherocytosis, 2 of which died. And there have been many other advances in our understanding of the function of the spleen since then, but really this is the overarching or overwhelming primary consideration, that it's an important and essential component of our immune system, and taking the spleen out is not without its consequences. So unlike what Coker said, that the spleen has no evil effects, in fact, the opposite is true. And if any of you have had a patient die of post-splenectomy infection, as I have, you'll understand what I mean. It's a devastating problem, and it occurs in the space of 24 hours. Now, to get into the history again, this man, Tim Wansborough, was the right man in the right place at the right time to sort of try to change this accepted dogma and to look at splenic injuries from a different perspective. He was the chief of general surgery at the Hospital for Sick Children in the late 1940s and early 1950s. His son and my dad actually were fraternity brothers at the University of Toronto and lifelong friends, so I had a slight connection to him. And in late 1940s, he had a patient who was admitted to the hospital with what he thought was a splenic injury, and he decided not to operate on him. And that unfortunate kid was run over by a streetcar later, and at the time of autopsy, the pathologist really made an observation that the spleen had been ruptured before and had healed, but there was a scar in it. And so Wansborough said, well, maybe we don't have to operate on every kid with a ruptured spleen. And he began to practice that and to influence his colleagues at the hospital and the people he taught and the successors at the Hospital for Sick Children. But it was never published or mentioned outside the Sick Kids Hospital. The first publication appeared in 1968, and the primary author was Jimmy Simpson, who was a very, very fast and skillful surgeon, the slickest surgeon at the hospital during my time as a resident there. He reported a series of 52 cases of ruptured, what he called ruptured spleen. 10 of them died of associated injuries, nothing to do with the spleen. 30 had a splenectomy, and 12 were treated non-operatively. And so this was the first time that any publication appeared in the surgical literature on non-operative management of splenic injuries. I first met Dr. Simpson on it a summer afternoon in 1968, which is the same year this publication was presented, when my little brother, Tom, we were at the summer cottage up in Lake Simcoe, and he developed abdominal pain, and we took him into the city to the hospital. And I was a pre-med student at the time, so my parents took me along because they thought I might learn something from the experience. And I remember two guys in white suits coming in and examining my brother, taking blood, and they actually went to the little lab in the emergency room where they did the white cell count themselves and called Dr. Simpson, and he came in, and before the sun had set, Dr. Simpson had taken out his spleen. There was no ultrasound, there was no CT scan, there was nothing fancy, and I was really impressed. And about 15 years later, when Dr. Simpson retired, he gave me all his library and his slides, and I still value the books that he lent me, because a lot of them contain information about thoracic surgery in kids that's not available anywhere else. But nobody outside Toronto believed him. People said, there's no way that this is possible. We all know that when you injure the spleen, it's going to bleed, and it's going to keep bleeding until you either take it out or the patient dies. And after all, because Dr. Simpson's diagnosis was all based on clinical examination of the patient, there was no objective way to support him. And many people said probably there were these kids that he had successfully treated non-operatively never had splenic injuries in the first place. And that's where technology entered into the scene. And beginning in the late 1960s, early 1970s, the liver spleen scans were available on a 24/7 basis at Sick Kids Hospital. And it was at that time when we were first able to document objectively the presence or absence of a splenic injury. And this is the kind of scan we would get that you can see that looks as if the spleen is broken into two pieces in a child who had a blunt abdominal injury. So these scans were available at the hospital just like CT scans are today, and it became the basis of our management of these patients, and it allowed us for the first time to kind of prove that non-operative management was possible. This is where I sort of came in from a medical point of view. I was just finishing my fellowship when they asked me to update the experience with splenic injuries at the hospital, and we did a review of a consecutive series of cases. All of them were confirmed by operation or scan. So this was the first publication that really had objective evidence that some of these kids had really had splenic injuries that were treated successfully without operation. Only 30% of them had an operation, and the indications for operation were basically surgeon's judgment, clinical assessment. There were no standard criteria or guidelines that we used at the time in order to select patients for surgery versus non-operative therapy. And of the 19 that were operated on, 15 had splenectomy. And you'll see that as time goes by, the proportion of patients who even needed an operation who had a splenectomy goes down and down until you can almost save 100% of the splenic injury patients. Of the patients that were treated non-operatively, there were no deaths. They were all admitted to the ICU. So there was a long hospital stay at that time. We still had this notion in the back of our minds that there was a possibility of delayed rupture. 16 of the 44 required a blood transfusion, and the volume of blood given was 31 mils per kilo on average. In those days, unlike, we used either whole blood or reconstituted whole blood, and it seems we've almost come full circle in that in the 21st century. And all of the operations occurred within 16 hours of admission. There was no case of delayed rupture in this whole series of 44 non-operative cases. So people said, "Oh, I don't believe you. Those patients that you're showing, they had congenital anomalies of the spleen." And that really wasn't a splenic injury. So even though we had pretty good evidence, people still denied the evidence that we were trying to show them. But this is a scan of the same child that I just showed you, because we always used to get follow-up scans 6 or 8 weeks later, and this is the same patient showing that the spleen had completely healed. So, we could dispense with that argument that we were only dealing with splenic malformations, not true splenic injuries. So to say that this paper was not well received is kind of an understatement. We were basically vilified by the entire surgical community around North America, including all the pediatric surgeons and the general surgeons that had experience with trauma. I don't know if you've ever heard of Bill Blaisdell, but he was one of the big surgeons at San Francisco General. And he said, if you believe, this was a quote from a presentation he made at an ACS meeting in Florida back in 1986, which was sometime after our publication. If you believe surgery aggravates bleeding, then you shouldn't even be in surgery. We probably have more experience in managing kids than any pediatric surgeon will ever see because they don't see that much. So now, even if you haven't heard of Blaisdell, you've probably heard of Don Trunke. And this is what Dr. Trunke had to say about our paper and our idea. They gave all those children that they managed conservatively 30 mils per kilo body weight of blood, which was not true. The second thing is that their operative mortality from bleeding from the spleen was 5%, which was not true. I just don't see any rationale for their approach. At the time, they would say things like, oh, we operate on a day, they come in, they go home in 4 days, and then we never see them again, everything's fine. And of course, anybody who's a surgeon knows that is a very oversimplification of what really happens. Now, fortunately, the guy who wrote this article, which had all these quotes in it, contacted me. And although I was a young guy, I was like 3 or 4 years out of my fellowship and fairly inexperienced, this is what I had to say. And all of these quotes were published in the same publication from the College of Surgeons that appeared after this meeting. And really, we were able to refute everything that they said. None of the patients had any complications, and all subsequently recovered without surgery. They walked out and are now perfectly normal individuals. So what was really the problem? I think the problem was that our diagnostic tools have become much better. We were much more able to establish the diagnosis of splenic injury. The CT scan and the radionuclide imaging scans were much more sensitive than clinical examination. Prior to the availability of these scans, the diagnosis of splenic rupture was made in a patient who'd had a blunt injury but who had shown signs of hemorrhage. And basically, those patients were in hemorrhagic shock. And with the advent of CT and radionuclide imaging, we began to realize that we had only been seeing the tip of this sort of injury, splenic injury iceberg. You know, there was a lot of patients that were never clinically recognized. And although we weren't aware of it, we had always been treating patients selectively because we weren't able to diagnose those occult splenic injuries that we can see nowadays. So in those days, a ruptured spleen, prior to these scans, a ruptured spleen was basically a patient in shock from a blunt abdominal injury. Now a ruptured spleen is usually just a patient who's had a blunt injury to the abdomen who may or may not even have any signs or symptoms and possibly doesn't have any evidence of blood loss, but we get these scans anyway, and now we see all these injuries that otherwise we would never have known about. Now, a couple of years later, we published another paper, which is a follow-up, and there were two reasons behind this paper. One was to confirm that the non-operative patients required very little blood, and second, to show what our experience was after we instituted this policy of only doing a laparotomy for kids who required more than 40 mils per kilogram of blood. As you remember, in the first paper, all the patients that were successfully treated non-operatively either didn't need any blood or on average needed about 30 mils per kilo, which is a little bit less than half a blood volume on average. So that we started to use that as our main criterion for selecting patients for surgery. And frankly, I don't think there's been any a better criterion for the decision to do an operation or any kind of intervention since then. You see that in the first paper, the 15 of the 19 that we had to operate on had a splenectomy. In this paper, only 3 of the 10 that were operated on needed a splenectomy. The others were patched up in some way so that the spleen was saved. So the overall splenic salvage rate was 96%. And this is the sort of what happened to the patients who were treated non-operatively. All survived. Only 15 of 65 required a blood transfusion, and the average was 22 mils per kilo. And most of these had other injuries. Only 20 were admitted to the ICU. You can see that we gradually ratcheted down the length of time in the hospital overall and the length of time in the operating room. So the next sort of chapter in the story was kind of the standardization of non-operative or selective non-operative management of splenic injuries and a more rational use of resources to essentially reduce the use of blood products, reduce the ICU stay and the total length of stay, and reduce the use of scans, etc. And this was all worked out by the committee at the American Pediatric Surgical Association, led by Stephen Stylianos, who's a surgeon who's currently practicing in New York City. And these are the guidelines that Dr. Stylianos' committee came up with. You can see that the cases are classified according to CT grading of the severity of the injury, grade 1, grade 2, grade 3, grade 4. None of them, except for the ones with grade 4 injury, required admission to the ICU. The number of hospital days is basically the grade plus 1. So for grade 1 injuries, it's a 2 days in hospital. Grade 2 is 3 days in hospital, etc. And there was agreement that no pre-discharge or post-discharge scanning of any kind was necessary. So once the diagnosis had been established, it was recommended that no further imaging be done. And Stylianos subsequently published a paper that was a multi-center report of the impact of these guidelines on the use of resources in the management of patients with splenic injuries. And the bottom line is that overall there was a major reduction in the ICU days, the length of stay, the use of imaging, and activity restriction as a result of the implication of these guidelines. Now, it hasn't really saved lives, but it certainly reduced the use of resources, and non-operative care succeeds in more than 90% of cases. But there was still a big controversy between the pediatric surgery world and the general surgery world, of the trauma surgery world around North America. And this is important because about 80% of, according to discharge data that you can get, 80% of kids with splenic injuries in the U.S. are treated in general hospitals, not in children's hospitals. But a number of reports have documented that the risk of operation and of splenectomy is much higher for patients that are treated in general hospitals by general surgeons. So the risk of operation is higher when the patient is treated by a general surgeon or a trauma surgeon at a trauma center or a general hospital versus a children's hospital and at a non-teaching hospital. Over time, these differences of opinion have kind of faded away, and according to the National Trauma Database, which is a big database that collects data from all across North America, even for adults, there's now 76% of patients who are treated in hospital for a ruptured spleen or splenic injuries are treated non-operatively. So this has finally been accepted by the adult trauma world. The current guidelines, which the best version of the current recommended best practices are published by the Eastern Association for the Surgery of Trauma, and they're easily available on their website. And they basically divide patients with injured spleens into two groups, those with unstable vital signs and those with stable vital signs. They recommend immediate operation for patients who are hemodynamically unstable. And for those who are not hemodynamically unstable, they recommend non-operative therapy or non-operative management, but that requires frequent monitoring by a surgeon, frequent vital signs monitoring, the availability of an operating room immediately, and the availability of blood for blood transfusion if required. There's really no evidence that there's any way to classify patients according to their risk or the need for operation based on their CT findings. Whether it's a grade 4 injury or a grade 2 injury doesn't seem to make any difference, and the amount of hemoperitoneum that you can see on the scan doesn't seem to be a useful criterion for deciding whether to operate. It's mainly the hemodynamic stability that's important. The whole business of embolization versus open surgery with splenectomy or splenectomy is still up in the air. I think it really depends on the local expertise, but certainly embolization is definitely an adjunct in patients who are hemodynamically stable who require a lot of blood. So it took a lot of time, but I don't think there's anybody who would question the potential benefits of non-operative management of splenic injuries. It's pretty widely accepted now among general surgeons, trauma surgeons, and pediatric surgeons that this is the wise thing. And if you look back on the whole history of what happened over the period from the 1960s to the current, I think you can see several stages. The first stage was basically, well, your patients didn't even have splenic injuries, which you might call that denial. The second stage was, well, you pediatric surgeons don't even know how to care for injured children, which was kind of an angry response. And the third stage was, well, it may work for kids, but it doesn't work for adults, which is sort of a bargaining thing. And the final stage was, well, now we don't even get to operate anymore, and we can't teach our residents how to do an exploratory laparotomy because of what you guys have done. And that's sort of like a depression kind of an example. The final stage has really been acceptance of the reality of this. Now, on the understanding the resources to monitor and care for a patient if hemorrhage and bleeding, hemorrhage develops and an intervention is necessary, are always available. Now, there's still some barriers to this non-operative management of splenic injury. There's no question that the risk of operative intervention seems to be higher in general hospitals. It's higher in for-profit hospitals, which is not such a big thing here in Canada, but certainly there are many for-profit hospitals in the U.S., and the data that you can get from the discharge abstracts indicate that for-profit hospitals have a much higher operative rate. Whether it's a trauma center or a non-trauma center shouldn't matter, but the risk of surgery is actually higher still in non-trauma center hospitals and in rural versus urban hospitals. And the same for general surgeons and trauma surgeons versus pediatric surgeons. There's still a higher incidence of surgical intervention for splenic injury when controlling for all the other parameters like age and CT grade, etc. But I think that the last three on this list, lack of experience with pediatric trauma, inability to monitor continuously, or lack of immediate OR availability, are legitimate reasons to maybe intervene in some way, either primarily with surgical intervention, if you don't have those tools to continuously monitor and intervene if the patient's condition changes. So there are some circumstances where I think that an operation might be indicated if all the tools that we have available at our tertiary hospitals and our major children's hospitals are not available. There's still a number of unsolved questions. I mentioned earlier that we use the 40 mils per kilogram or half a blood volume as the criterion for deciding to operate on the patient. There's never been anything published subsequently that is a valid guide to decide when to intervene. The same goes for the need for transfusion, the indications for how much blood the patient should get, whether contrast extravasation is an indication for intervention. But I think that lack of resources, lack of experienced personnel, blood banking, ICU, OR availability are certainly legitimate indications to operate if you're particularly in a remote area. Now, this is a slide from a patient of mine recently who had a splenic injury resulting from he actually ran into another kid on the soccer field. And you can see there's some extravasation of contrast here and a fairly massive hemoperitoneum. And, you know, I think this child was successfully treated non-operatively. He received one transfusion and subsequently recovered without any further problems. But I think the scanning that we have now is a little bit more sensitive, so that while extravasation of dye 25 years ago meant more massive bleeding than we are able to pick up nowadays. So I don't think that extravasation is really a valid indication to intervene either with embolization or with surgery. So I think in the end, this whole controversy over the management of splenic injuries was not settled by argument. It was settled by our better understanding of the need for the spleen to be saved if possible because of its essential role in the immune system. Also, the context in which we practice, because we're much more able to make a diagnosis of splenic injury, so the incidence has gone up considerably. We now have reliable IV access. We have the benefits of intensive care unit and safe blood transfusion so that we can afford to watch some of these patients after they've been admitted. And we do have alternate treatment options, including embolization, available at the most advanced hospitals. So in summary, I would say that there's really no right way for all times and all places, and just in 2013, just as was true in 1913, the best way to manage these kids depends on our sort of understanding of the biology of the spleen and the functions of the spleen, the resources that are available or needed to support a patient, and to be able to monitor a patient and have a surgeon available to operate if necessary. So I think that I'll end at that point. I think all the controversy about splenic trauma is understandable if you understand the context in which it developed and how our knowledge about the spleen and our technology and our ability to support a patient, particularly if bleeding happens, has developed over the last 100 years. I think it's much more easy to understand. And I know I have deliberately left a lot of time for questions, so I'm sure you guys have some questions. If you want to ask them, I'd be happy to do that. Go ahead. I'm going to try the technology here. And if you hit the little thing by your, this is so that we can, the people at the remote sites will be able to hear what we're talking about.
Anybody who wants to ask a question pushes a button.
Guy who has the green button.
I got green now.
Okay.
So can you tell me a little bit more about the dichotomy, the decision making between embolization and splenectomy? Because I think that's something we face now.
Yeah.
When to do either, and how are you guys approaching that?
There's no, we use embolization. There's no evidence-based basis on which to make that decision. I think where it's available and you have the opportunity to get embolization done on a short-term basis, 24/7, I think that that's certainly a legitimate way of dealing with these patients. And I don't think you can say in a given patient that this patient is suitable for embolization or this patient is not suitable for embolization. I think that if there's ongoing blood loss, hemodynamic instability, I think that depending on how unstable the patient is, embolization I think is a valid consideration. Now, not every hospital has it available, obviously. There are many hospitals that don't have IR and many more remote rural hospitals that need to depend on surgery to deal with the problem.
I think sometimes we see unstable patients getting embolization. I don't know.
Well, they really shouldn't be unstable when they're in the radiology department. I mean, I guess it depends a little bit on what you mean by unstable. Most of the patients, like the child that I showed you with the extravasation, respond to a single transfusion. That's sort of my rule of thumb. If the patient can be stabilized after one transfusion, and then I would not operate on them. But if they continue to require blood, and even if they do respond to repeated transfusions, those are the kinds of patients that I think you'd consider embolization. There is the rare case that comes into the emergency room with low blood pressure, shock, obvious, and you give blood and they still don't stabilize. Those patients, I think, probably should go to the operating room, in my opinion. I think I do next. Just talk. Oh yeah, it's right by the disc. Where the microphone is. So go ahead. I did hit next.
Try. Oh, okay. All right. Good. So I'm curious to figure out how to balance this, because in some mostly penetrating trauma, we're using some permissive hypotension now.
Yeah.
And when we identify this guy obviously needs to go to the OR, let's just minimize what we give him and get him to surgery. And so I'm just trying to balance how you figure out who you keep in emerge and try to transfuse to see if they stabilize. And is there any way to predict like who's not going to respond and should just go straight to surgery? Because you said that the CT doesn't really correlate with who needs.
I don't
surgery.
think that Dr. Ken Maddox, who's one of the other surgeons in our department, started this whole controversy 20 years ago or so, when they published a paper that tried to show that patients did better, trauma patients with penetrating injuries did better if you didn't try to resuscitate them with large volumes of fluid and blood before you took them to the operating room. And that was a study that was, the patients were randomly allocated, but it was based on the day that they were treated. It wasn't a true randomization, and it wasn't really, there was no real way to prove that, in fact, everything else was controlled adequately. But that's still the practice in Houston, that they avoid giving volumes of blood or fluids before taking a patient to the operating room with penetrating injuries. And I think that's a different category. We don't really have, I personally don't have very much experience at all with penetrating trauma in children. There, we do get the odd case, but it's usually, clear that you need to take the patient to the operating room. You don't necessarily have to do any scanning or anything like that. But I don't think that I or any of the other pediatric surgeons that I know would recommend permissive hypotension in a patient with a blunt injury. I think that we try to resuscitate them adequately and restore their blood volume and their Metacritic. Are there any other questions? Comments? Sir?
Is the next after the person has pressed their red?
Okay. To go green?
Yeah, I did.
Oh, good. You're on.
Thanks very much for the presentation, Dr. Wesson. Really enjoyed it. Do you want to comment, I'm a surgeon, do you want to comment a bit about your techniques of saving and salvaging spleens in the operating room?
Yeah. Well, I used to be kind of sarcastic about this in the sense that the ones that you're easily able to salvage in the operating room are the ones that probably didn't need operating in the first place. When the spleen is completely pulverized, then there's really not much you can do. But I think I would divide the patients that you're talking about into two groups, the ones that have multiple intra-abdominal injuries, in which case I think the most expedient thing to do is to rapidly take out the spleen if there's a liver injury or bowel injuries or other problems that you have to, pancreas injuries that you have to deal with at the time. Packing and suturing are, options that you can use. It's been a long time since I've operated on a splenic injury. I do remember a very interesting case. One time we had a baby. It was a birth trauma, actually. It had a ruptured spleen that we were operating on, and we were particularly concerned about saving the spleen because of the age of the child. And one of the scrub nurses, we got those little chest tubes, the 12 French chest tubes that come with the big trocar in them. Look just like knitting needles. Well, we took a couple of long spools of Exxon ligature, and she knitted a little hair net that we put around the spleen, and we were packing it. In the meanwhile, it took her about 10 minutes to do. She was Scottish. Very interesting. Sort of ironic that she was an RNA, what they call it. I don't know if you have RNAs here, but they're nursing assistants that didn't have a bachelor's degree in nursing, and she was subsequently let go by the hospital because she wasn't well qualified. It sort of seems ridiculous in retrospect. But you can get those little meshes now. I don't know whether you stock them in the operating room, but the people that might make Vicryl and produce them. I don't have any magic, and I don't have any great experience. I've done quite a few surgical procedures on the spleen electively for cysts and other things, and it's amazing how much surgery you can do on the spleen and still control the bleeding successfully. Many of my colleagues, I don't personally do this, but are doing hemisplenectomies now for the various hematological disorders that we see, like serocytosis, in order to preserve some splenic function. And as long as you're careful, you use a lot of cautery, you can usually transect the spleen along its crosswise. And I don't have any other magic solutions. All right, try again.
Does
Oh. Did you go green?
did somebody else turn green?
Well, speak up and I'll repeat the question. Well, I don't think we know the answer to that question. There have been a number of animal experiments that try to assess the function of the spleen after partial splenectomy. And the rule that I kind of carry in my mind is that if you can preserve at least a third of the spleen with its intact blood supply, it will function normally. Little bits of spleen I don't think are effective in that sense. One of my teachers used to always ligate the splenic artery in doing pancreatectomies in babies for idiopathic hyperinsulinemia, and leaving the short gastrics intact, and the spleen seemed to function normally by scan and also by looking at the blood smear. You don't see these Howell-Jolly body if you do that. So I would presume as long as you're embolizing the spleen, the splenic artery, if you embolize every single branch of the splenic artery and the spleen completely infarcts, I think it's probably not going to function. But I think that you could make a strong case that that's better than having a laparotomy and having your spleen taken out. I think that it's easy to test the function of the spleen, at least according to looking at the blood smear in a patient who's had that kind of procedure, and I certainly would recommend that.
Amanda Barkley and I had a case a couple years ago. I think we presented at Trauma Rounds at one point, and we radiology completely embolized the spleen. We couldn't see any blood. I mean, we couldn't see it. It was there, but it had been fully embolized, no blood flow to it. And 2 years later, she had a normal spleen, based on function and an ultrasound. And it was just amazing. We didn't even expect it. So again, what Dr. Wesson said, you could try it and see what happens, right? It's certainly better than the laparotomy.
Any other questions, comments, thoughts? What do the general surgeons feel about the role of this approach in adults? Is there still a controversy, or is it pretty much settled?
We follow the same approach. We try and not offer. We're fortunate here to have a very good interventional radiology.
Yeah.
Embolize on the thing, but every now and then we have these cases that don't respond, and we have to sometimes operate on them. We had one years ago.
I think it's one of the blessings of being in a big general hospital environment. You have a lot of these other resources available in the radiology department that not all children's hospitals. Our interventional radiology service is relatively new. They don't, and I'm sure that you're fortunate to have that here. Well, thank you all very much for your attention and for inviting me here. It's been a pleasure. All right. People understand?
Oh, yeah. That was